So, hello everyone. Today we are discussing a clinical approach to a pediatric case. Now, for a pediatric case, I have tried to cover all the five cases in a pediatric, which is the most commonly asked five pediatric cases, and I have combined them in a one single case. So, the five cases which we will be discussing, one would be a child which has a fever. So, a child with a fever, then child with a cough, then child with abnormal body movements. We will be covering a CNS also, and a child with loose motions. So a part of GIT we will tend to cover, and a child with swelling. So that child with swelling, generalized swelling. So we will be discussing about a nephrotic syndrome also. So all these five cases we have tried to combine in a one single case at some point in the history of a single child. All these features we will be dealing here. Now, what's important while we talk about a pediatric case, you don't have to dwell too much on the history of present illness. That is important, yes, but more important for a medicine case than a pediatric case. For a pediatric case, in the section of introduction, the most important thing is that you mention the informant, because the child himself or herself would not be presenting to you with the complaints. Obviously, you need a reliable informant. One thing is important in a pediatric case is this for intro. The history of present illness, as I talked about, is not of much importance. But in a history, the immunization history is most important. You need to mention the immunization. You need to have the NIS schedule on tips. The developmental history is important. You need to know the milestones and the milestones appropriate for a particular age group which has been allotted to you. If a 14-year child is given to you, you don't start that the child has achieved a neck holding at 3 months unless and until it is a cerebral palsy case. So even in cerebral palsy case, even at the age of 10 years or 14 years, a child is still not able to hold his head. So the head holding is not still achieved. That is obviously a global developmental delay. But the child who is well and is presented to you, you just ask for the academic background. Is the child able to concentrate or having an attention properly or not? In which class the child is studying? As well as since the puberty the child has reached. So what is the Tanner staging? So you need to classify it as put in a Tanner stage for a 14-year age group. So accordingly, the different ages group matter. So for immunization, you need to know for developmental history, the milestones you need to have on tips, the dietary history. The dietary history is of utmost importance. You can flunder upon a history of present illness, but not on the dietary history. In every case, in every pediatric age group, dietary history has to be taken. Okay. Then in examination, more important than a systemic examination, the general physical examination is of utmost importance along with the anthropometry. So in every child, anthropometry has to be taken. Even if the child is a 16-year-old, yes, you need to take an anthropometry. For that, it would be a weight and a height, and then you have to calculate the BMI and plot it on an IAP growth chart. Okay. So these are the things which we will discuss in more details, and these are the things which are more focused in a pediatric case than the history of present illness. Yes, we will be discussing it, but focus should be more on them. So let's start. Master B, a 4-year boy, resident of Bulandshahr, Uttar Pradesh. Informant, as I talked about, informant has to be mentioned. The informant is his mother, Mrs. X, and she is reliable. How the informant is reliable? Because the informant lives with the child and is know that what the child is suffering from and what are the complaints of the child. So the mother is a reliable informant. Fine. Next thing which in pediatric is important to mention is the socioeconomic status, that the family belongs to a lower class by modified Kupfman scale. How we calculated it is easy, and you have to calculate it. The three components should be HES, that is the salary, that is the monthly family income, education of the head of the family, and the occupation of the head of the family. So for salary, we asked they were earning like 7,000 per month. So according to the CPI, we graded in a score of 1. Education of the head of the family, the father is a fourth standard pass, so it's a primary level of education 1, and he's a labor by occupation. So he's a laborer by occupation. There's an unskilled worker, so it's 1, and the total calculated to be 3. So anything less than 5 belongs to a lower class, 5 to 10 belongs to the upper lower. Okay, in government setup, you are most likely to find these cases only. uh, otherwise you just need to have a tip. You can just have an estimation. If yes, the education, if the family is graduate or a postgraduate, you can score it like a 10 or 11 or 15 to score it, and then yes, it would be a middle class family. Then the date of admission and date of examination is of importance, because while in the pediatric case the children are admitted for a long period of time, it even takes a month. So during that course, during hospital stay, a lot of history varies, and as well as the examinations also vary. So while you're presenting up the case, you need to be clear that yes, the date of admission here, it is just a 1 day, and date of examination is 3rd August 2023. But for a longer course during the hospital stay, you can mention the date of admission and date of examination. Fine. Then we move on to the chief complaints. So as I talked about, for the chief complaints, most of the time only one single chief complaint or two chief complaints would be presented to you to present a case. Either it would be a RESP case or a CNS case or a GI case or a CNS case. Here I have tried to combine up all these cases for the ease of discussion. But still, the more importance would not be given to the history of present illness. Rather, the more importance should be given on to the developmental history and the immunization history. Here, our child is presenting with the fever for 1 week. Okay, so the fever is there from 1 week, from the past 1 week. You need to know that vaguely what kind of etiologies would be there in a child. Then the child is also having cough from 1 week. So here, this cough from 1 week and a fever is making me think of a RESP case, because both of them are simultaneously occurring from past 1 week. For loose stools from past 2 days, I may think of a GIT case. I may think of a GIT case because the child is having a diarrhea. Okay, and this is just a past 2 days history, so it is an acute diarrhea. Okay, I can think of some dysenteries if there would be a blood, enteric fever, typhoid fever, most commonly salmonella infection. If there is a blood, dysentery, shigella infections, most commonly I see E. coli. But uh, here, when I just combine these histories, that yes, there is a fever and there is a cough and there is a loose stools associatedly with them. So more likely, I think that yes, the fever and the cough was going from past 1 week. It would be a RESP case, and since there is a fever, I can might think of an infective etiology also, which has lead to this loose stool as associated symptom rather than itself a pathology. Okay, so sometimes in RESP cases, we do get a complaint of a loose tooth also in children. And then there is a abnormal body movement. So here I can think of a CNS etiology. Just from past 1 day, the child is having abnormal body movement. Now this abnormal body movement could be anything. It could be a seizure, not yet sure. We need to confirm it by detailed history as well as on examination. It could be some behavioral abnormalities also, because in child there are tantrums and there is behavioral disorders also, where the child tends to mimic them. So let's move on to history of present illness in a very fast way. According to the mother, has to be specified. The child was well. The child developed fever. Then we need to explain. Yes, it was continuous. It was 103 degree Fahrenheit. Is it a high grade or a low grade? For a high grade fever, usually if you have documented it, you just mention as to a 103 degree Fahrenheit. For a high grade, if it is not being documented yet, we should be aware that it should be 105 degree or high. Then we say that it is extremely a high grade fever. Okay, it is associated with chills relieved on taking paracetamol. Okay, so the child has been on a medication, and most probably a local practitioner would have prescribed, or mostly from pharmacy, the parents over the counter, they takes the pills, and it is not associated with rash. If it would have been associated with rash, we are ruling out here measles, because it is the most common infections in children, rash, fever with rash. Other than that, we can have some papules and fistules if are there, or vesicles are there. We can think of chickenpox also, which is common in childhood. There is no evening rise of temperature. So for evening rise of temperature, we are trying to rule out any tuberculosis infection, because in TB there is a low grade fever and there is an evening rise. Only the fever, if there is, it would be increasing in the evening. And yes, it is associated with cough of at least 2 weeks. Other than that, the history which we has taken, it is in the month of August. So in month of August, the other differentials for fever which we can think of is malaria also, and dengue also. It's a monsoon season, malaria, dengue or chikungunya. these infections can also occur in the child. So let's see, but obviously they would not be presenting it with the cough. There is a cough, there would be some more underlying respiratory illness as far we are clear about it. The child has also developed cough. It is also from 1 week, insidious. It is not multiple episodes are there. It is without expectorations. Okay, if it would have been with expectoration, we would have taken up what would be the amount. It is mucoid stain, watery, what kind of sputum is there. We would have taken it in more detail. Okay, there is no difficulty in breathing, so we are just trying to figure out is there any respiratory distress or not. Then the mother has complained of the child is having the loose stools. Okay, the mother having the 2 days history of diarrhea. So for diarrhea, if it is 14 days, we say it to be a persistent diarrhea, and more than that, we term it as a chronic diarrhea. And then the etiologies turn out to be different for any malformations or not. Then we think of a persistent or a chronic etiology. Here, it is an acute diarrhea. So acute diarrhea is most commonly associated with an infective etiology. Okay, so it could be an associated symptom to a respiratory illness also, or a separate, if a separate case as a child with a loose stools would be there, then you are thinking of an acute diarrhea in a different infective etiology, as I talked about of enteric fever. Then it is 5 to 6 times a day, water in consistency. We need to specify yellowish color. If it would have been a greenish color stools, then I know that I would be thinking about a pseudomonas infection. And if there would be it is a rice watery stool, then I would be thinking about a cholera infection. Okay, so these that's why the detailed history has to be taken. If there would have been a dark colored stool, okay, it is not blood stain, or if it is a dark colored stool, that is melena, the history of melena, I would be thinking about a upper GI bleed. Or it would be a frank red blood which I would be seeing, then it would be a lower GI bleed. Okay, and that's why the detailed history is important. No mucus stain, no abdominal fine. Jaundice history has to be taken out, because what happens in jaundice history, if we have a fever and abdominal pain as well as a vomiting in a GI, the most common case which we are allotted is of hepatitis also. And then we need to know this hepatitis, is it of an infective etiology, where I say it could be a viral or amoebic entamoeba histolica infections, viral hepatitis or amoebic hepatitis. Other than that, it could be a case of also a liver abscess. So these cases are allotted, and they are quite a common case. Okay, the jaundice would be more prevalent towards it, and in liver abscess, a fever would be more prevalent. Then we have a case or a complaint pointing towards a CNS etiology, that one day back the mother noticed abnormal body movement. Here a detailed history is important, because yes, we need to first confirm that is it a seizure or not. Okay, as I talked about, there are a lot of behavioral disorders in children. So abnormal body movement in the child, now it is begins with a stiffness. So why this stiffness? This stiffness is indicating towards a tonic. You need to take a detail, and for abnormal body movement, it is always important that you asked the mother that is this episode has been videographed or not. Is it the first episode, or the child repeatedly have these kind of, and is it videographed or not? Then you can easily make that is it a seizure or not. If the mother hasn't videographed, you ask in a more detail that yes, what happened step by step. The first child has a stiffness, so there is a tone is increased, so it is a tonic, and then there is followed by a jerky movement. So it is a jerky movement, so I know it is pointing towards a myoclonic also. So there is some tone and a myocloniness also, and it is not limited to one part of the body, it is involving the whole of the body, and it is lasting. Are there any periods of unconsciousness or not, to label it as an epileptic episode or not? Okay, I have to mention it also. Then most important thing is that the child started crying before, and he bite his tongue also. So here now I know that yes, the biting tongue is there, it could be a seizure. Other than that, frothy mouth or any discharge coming from mouth also point me towards a seizure part. Then for that, usually in a 4 year child, I would not be asking for any birth complications unless and until this type of history is presented to me, because this history of birth complication will tell me to rule out asphyxias or hypoxia at an early stage, the child immediately cried at birth or not. That is, I'm trying to rule out HIE, hypoxic ischemic encephalopathies, because the later on in childhood they present as frequent seizures episode, and obviously then delayed milestone would be noticed. So here there is no birth complications or any recent ear discharge. Here I'm trying to rule out otitis media, these infections. Any trauma history or there any similar attack, if there are any in infancies, headache, weakness, disturbances, swaying or unsteadiness, any kind of cerebral involvement or not is there. So that much detailed history I have to take in cases of any abnormal body movement. What normally happens in typically in teenage groups, we see a phenomena that is of psychogenic seizure. So you need to ask an emotional background also. The child usually have this attack while they are lying down on bed or they're sitting on bed, and they just fall on the bed itself. They don't have a history of falling somewhere, and they don't have such jerky movements or stiffness. So these psychogenic seizures are usually followed by some emotional disturbance or emotional trigger factors you need to rule out, and it is seen in a teenage group. So these abnormal body movements we have to take up the history. And for a seizure in children, we know that there is a partial and complex seizure which is common, and also absent seizure is common. So in cases of absent seizure, there would be a blank staring gaze. So like if I say that if I'm talking to you, the child would hyperventilate. The child, if you ask the child to hyperventilate, a lot of like this. So yes, what I was talking about. So this was an absent seizure. After hyperventilation, there was a blank staring gait, and then as soon as the seizure episode vanishes, I resume to my normal activity. There would be a no post-ictal confusion. So there is no post-ictal confusion. That after the episode, I'm not having any confusion. There is no loss of memory, and I'm resuming my all work. So this is would be an absent seizure which is noticed in the child. And other than that, here that like there is an history of a fever, but the fever would be a preceding just somewhere before the episodes. If there is a high grade fever the child is experiencing, and then the child develops this fever, then it would be a febrile seizure, the episode of febrile seizure. So there are a lot of seizures as we talked about. Then past history is important, that here we see that there is no episode of any similar episodes in the child, and the child is a known case of nephrotic syndrome. So the five cases which we talked about here, the fifth one which we need to understand, this nephrotic syndrome, while it is of a 2 year back. Okay, it was 2 years back. So at 2 years back, if I talk about what would be the chief complaints, the chief complaints would be swelling, and this swelling would be beginning with the legs, and then would be spreading, involving the trunk, and then the face, legs, arms, limbs, and the face. And this facial puffiness, it could be around the eyes, that I would say as a periorbital edema in cases of nephritic syndrome, or it involving whole of the body, which I say as anasarca in cases of nephrotic syndrome. And when we check for the BPs of these children, it is quite raised. So this would be a case of nephrotic syndrome with generalized swelling if it is being presented. Now, it could be a first episode of nephrotic syndrome, or it could be a relapsing recurrent episodes of the nephrotic syndrome. Once they are treated, the most common cause of the nephrotic syndrome, while we perform the biopsy in these children, we say it is a MCD, or the minimal change disease. So this minimal change disease, why it is named as minimal change disease, because while we perform the microscopy, the no much changes are visible in them. So it is minimal change. While we perform it on electron microscopy, only on electron microscopy we can see this, that is the effacement of the podocytes. So the podocytes are effaced, and that's why there is a proteinuria. The protein is being lost, and that is resulting in the osmotic imbalance, and the water is being fluid has been retained, and thus which is leading to a swelling. So it is to be a biopsy proven. This is a minimal change disease. If it is an immunocompromised state or a HIV children, then we know it would be an FSGA, focal segmental glomerulopathy. The cause would be different. More commonly, the cause would be different. Then What would be the treatment for it? The treatment, after confirming it to be a case of nephrotic syndrome, most importantly in history, one, we will ask for any cola colored urine or smoky urine, we will ask. And for this, we are ruling out any PSGN, and more commonly now it is known as PIGN, that is infective glomerulonephritis, post-tubercle glomerulonephritis, or infective glomerulonephritis in cases of nephritic syndromes. For hypertensions or not, right? And for treatment, we will begin with corticosteroids, steroids, that is more commonly it is used as prednisolone, and usually it is given for a week, for 4 weeks, or and then we taper the dose, so in about 2 months the child recover. And if there are no chances of relapse or remissions, we just continue at the dose for a quite longer period, so that there are no remissions in the child. And yes, it can be a reversible change. So that was a little discussion about nephrotic syndrome. Then there is no history of blood transfusion, any major surgical procedure, antenatal, natal, and postnatal history. This is of importance if the child is of less than 1 year age. If it is a case which is allotted to a less than 1 year of age, then you take a detailed natal, antenatal, postnatal history. Here it is of not much importance if the child age is 4 years, but still we are considering it because the child has complained of an abnormal body movement, and we still need to rule out HIE, though we have taken up in the history. But here also we will discuss that more, that what the pregnancy was, how it was confirmed the TD doses were taken or not. If it is more than 3 gaps, if it is first pregnancy, yes, 2D would be given. If the pregnancy, the previous pregnancy was 3 years back, then 2 doses would be given. If it is less than that, only one booster is given. Then iron, folic acid were taken or not, was it a full term or a cesarean, was it a preterm or not? Okay, because in child immediately cried at birth. Okay, so the child cried at birth, we are trying to rule out HIE here, and the birth doses were given, colostrum fine, everything is okay, but you need to mention that. Then our most important part, which is we need to know, that is immunization history. So you need to remember the NIS schedule thoroughly. Now here you don't have to start with the first birth dose in at 6, 10, 14. No, the relevant at a 4 year of age, I know that the last would be given at around uh, 18 to 24 months. And other than that, at 5th year, at the 5 year of age, one booster is given, so that would be due. So I just asked that, is it due, or is it due, you have to plan for it. So that is due. Until now the immunization is complete till date. Okay, I won't say the child is fully immunized, but the immunization is complete till date, right? And the birth doses at 18 to 24 months, we know it is MMR2, Japanese encephalitis, the resident of UP or Bihar. We give Japanese encephalitis, OPV booster, DPT booster, vitamin A, 1 big spoon. What is this 1 big spoon? Basically, in vitamin A, there is a bi-level spoon. There are two levels. The one inner level, it has 1 lakh international units, and the outer level has 2 lakh international units. Okay, so the children who are less than 1 year of age, we give them this 1 lakh international unit, and more than that 2 lakh international unit. Talking about NIS here, because it is, as I talked about, these are the most important points which are relevant to a pediatric case. Okay, so here we will discuss the NIS schedule a little more in detail, because as I talked about, it is of importance. So this national immunization schedule, we have a zero dose. We give a zero dose at 6, 10, and 14 week. So for zero, we know it is a BCG, which is given, the birth dose, the hepatitis B birth dose, and a OPV zero dose. Fine. Then at 6 and 14, we give fractionated IPV, and along with IPV, we give pneumococcal vaccine. Okay, so they are just given at 6 and 14, and IPV, PCV. Other than that, all this go in a same hand: OPV 1, OPV 2, OPV 3. Then we have Penta 1 and 2 and 3. And along with that, we have rotavirus also in some districts, which we give 1, 2, and 3. And this rotavirus, it is in a pink vial. Okay, this much is there. Then when we move from 6 and 14, we have 9 month. So at 9 month, we are giving the MMR vaccines. Earlier, it turned out to be like from starting it was MMR, then it was ruled out as MR, and now again in Delhi also it has been turned to MMR. So this MMR1 and along with MMR1, Japanese encephalitis in districts of Bihar and Jharkhand, and in then from this 9 to 16 month it is given, and then from 18 to 24 month we give this MMR2 and Japanese encephalitis 2, and all the boosters are given in this 16 to 24 month. We give all the kind of boosters, like we have this TPT booster, this OPV booster. Okay, and then we have at 5th year of age, which we were discussing, this DPT booster, which would be due. Then would be 10 year of age, we would be a TD booster, and at 16 year of it would be a TD booster. Okay, so this we have discussed. Then moving on to the developmental history. Okay, the DPT booster at 5 year of age. Then moving on to developmental history, which is of another importance, and we don't have to start with that at 3 months the child has developed a head holding. It is important in cases of global developmental delay or in cases of cerebral palsy. Here, our child is 4 year of age. So first we will talk about the relevant history, which is important here. So at a 4 year of age, the child would be going to a preschool or would be playing with friends. That much social we expect from the child. So that the plays with the friend, we will ask that does the child play with friend or go outside? Is the child able to go to the washroom alone? You have to ask that. Firstly, you have to categorize the developmental history into gross motor, fine motor, social, and language, and then one relevant point is asked. You don't have to just focus on all the gross motor, and you just because there is a table which is given in books, and you don't have to memorize all that table and ask that only the gross motor. You have to cover all those four aspects, and only one relevant point is enough. So for social, you have asked that is the child plays with friends, goes to toilet alone, and if the child able to sing a song or you tell a poem, because you make the child learn a poem, and then if the child is able to narrate it or if the child is able to tell you a story, then you check for these languages. Okay, you don't start the child has started cooing or monosyllables, bisyllables at what age or what age. Here it is not important because it is a 4 year old child. Then at a gross motor, you need to just ask that is the child able to use an alternate feet while climbing downstairs. If it is able to do, is able to hop on one feet, the gross motor is fine. For fine motor, you give a child a pen or a pencil and ask him to draw a cross, or is it's easy to remember a square? Because at 4 year, it is easy to remember the four sides which the child should be able to draw is a square. Clear? Then let's just discuss developmental history in a bit more detail according to the different age groups. If I have a child of a 3 month, so for a 3 month, I would be asking about the head holding, neck holding, if the child is able to hold his neck or not. And at the same time, I should be knowing that does the child recognize his mother and a social smile. So these things I have to ask in a 3 month old child. By 4 month, the child develops a bidextrous approach. And what's important at the age of 5 months and 6 months. So in a 6 month, the child is sitting in a tripod posture. Okay. And by 5 months, the child is able to roll in bed. So if the child is able to roll in bed and at the same time at around fifth or sixth month, the child is having a unidextrous approach as well as the child would be having a separation anxiety. And with this separation anxiety, by this fifth month of age, I'll be playing peekaboo also with the child. So the child would be able to play it and would be happy. Then by 9 month, I know the child would be standing and the child would be having a pincer grasp and would be saying me bye bye. By what do we know now that at 1 year of age the child is playing simple ball games. Okay. Then what is more important that at 9 and a 6 month, at 6 month the child is sitting with support, and at 9 month the child is standing with support. Both are with support. So at 6 month the child in language has monosyllables like ba, da, and at 9 months the child is having bisyllables like mama, dada. Be speaking. Okay. Then moving on to little higher age groups, that is 1.5 months. Sorry, moving at to a higher age group, that is 1.5 year. So for 1.5 year, the child would be able to run as well as make a cube of tower of a 4 cubes, and the child would start self feed. So he would be able to feed, he would be able to eat on his own plate, and the child would be having a 10-word vocabulary. Okay. By the age of 2 years, the child would jump and would be using spoon. He will use the spoon well to feed himself, and as well as he would be now making a tower of 7 cubes, a little double of it. Then by 3 years of age, so how we can remember this 3, 4, and 5? Let's make it at 3 years of age, 4 years of age, and 5 years of age. So the shapes which the child can draw, it would be a circle, four-sided square, and a triangle at 5 years of age, as well as a three. So tricycle he would be able to ride. Okay, would be able to ride a tricycle, as well as parallel play would be playable by a 3-year-old child. So parallel plays basically they play in a group, but not with each other. So they play individually, but they play in a group. At 4 year, as we discussed, the downwards stairs you would be able to do at alternatively by alternate feet, and by 5 years of age the child would be able to go to a kindergarten, so he would be able to dress himself properly, he would be learning to skip, and as well as would be. Then for older age groups like at puberty, we would be using Tanner stage. Okay, so we will classify it according to the Tanner stage in developmental history. So this much is important in developmental history, and at our age of 4, now we know that yes, we have described that is hopping on 1 foot alternate feet, copies a tower, square, and plays with friend, goes to toilet alone, tells a story in Singapore. Fine. Then another important aspect, as we talked about, is our dietary history, which is of utmost importance, and you just need to take in mind some commonly used Indian household items, and you can remember the rough values of it, which is easy to remember, like of banana, that is our 100 gram and 100 kilocalories would be there. 1 gram protein. For egg, it is 60 grams. One egg, 60 kilocalories, same as the grams it is, and the 6 gram protein. Then for carbohydrates, we know the 1 gram calorific value is 4 kilocalories, and for fats it is 9. So we just multiply for because it's made up of wheat, so we multiply it by 4 and we know it is 100. And similarly for some easy items like for cereals, and we know, and pulses, so the rough value it is of 300 kilocalories for every 100 grams, and for pulses it is 350 kilocalories. So this is a rough amount which we can remember vaguely and do a dietary chart. What's important is this, that you need to start that this dietary chart has been taken by a 24-hour recall method, and the two important things which where we don't take this is by when the child is fasting, is not having a food, and feasting. So whenever the child is consuming the food outside in a celebration, lunch or dinner, so we skip it and we take it yesterday or another day, one where a regular meal is being consumed. So we take the amounts of calories, proteins, and iron, and while describing it, we describe it not like one roti has been taken. We just describe it that yes, the dietary history has been taken by 24-hour recall method, which is deficit or excess in this much calories, proteins, and iron. Now, why it is so much deficit in iron? Because the group The food group of green leafy vegetables or watermelons is missing, so the child lacks iron. As well as now we see there is energy as well as protein malnutrition also in the child from the dietary history. Then how we calculate it, because we know need to know there is a one consumption unit which is approximately 2400 kilocalories, and approximately like 4 to 6 year of a child has half of one consumption unit, that is like 1200. And similarly you can calculate like for 10 or 12-year-old child you can calculate like to be 1800. For 3 to 2 years you can calculate to be roughly to be 1000. And just a rough estimation is needed, but it is a must in every pediatric case. The dietary history has to be taken. Okay, the personal history is of not much importance, just that any known allergies are not there in a family history. What is more important is your pedigree. So you always have to draw a pedigree. You don't have to start with no hypertension, diabetes. It is not relevant to a pediatric case. And you have to take the history of consanguinity or not, and you can ask it if the husband and wife they have married in relations, like if they are a relative, and you can just directly ask. And then also by relation you need to specify that are they a first or a second degree cousin or not, and then you will know. So for consanguinity the double line is being made between couple, and this is by consanguinity, this is non-consanguinity, and first to second degree generations are being plotted on a pedigree. This is are the case under study, the 4-year boy, and a 5-year gap is there between the siblings, 9-year. Then any diseased or the abortions, if I say the abortion is being identified as a triangle, and diseased by a line. Then there is no history of epilepsy. It is relevant because the child has an abnormal body movements, TB for any overcrowding, asthma or then hospital stay. Here it is of just 1 day, we can mention it. And the treatment history, the child has taken PCM tablets, over the counter, and ORS solutions, fine. Now he has been put on IV lines. So just summarizing up our case, that the reliable informant is of importance. The fever, we can think of different etiologies. It is a dry cough. Now we know that it is a respiratory case. Having diarrhea, so it could be an associated symptom towards it with a GTCS seizure. Now we are clear that yes, it is a GTCS seizure. One episode is there. So this respiratory must have some complications to reaching towards CNS. That much etiology you can think of. And then no other, we need to mention that the child is immunized, how much dietary is deficit, we also know now, and we can just club it that a 4-year boy is probably a case of acute febrile respiratory illness with GTS under evaluation with MCD 2 years back. So minimal changes is 2 years back. Okay, that much is clear from our history. Then moving on to general examination. So this general physical examination is of utmost importance, with anthropometry even more important than your systemic examination. So for general physical examination, we mentioned that the child is lying comfortably. We don't start with his oriented to time, place, and person, because the comfortability and irritability is of more importance here. And when the child is irritable, so we can know that yes, there would be some dehydration ongoing in the child. Okay. The pulse rate, it is taken in the brachial artery. It is not tachycardia. It is appropriate for the age. The respiratory rate, there is slightly tachypneic because the usual respiratory rate is 20 to 30. And the blood pressure has been taken. The temperature in CRT, it is less than 3 seconds. So for CRT in adults, usually we press the thumb and see the blanching and the return of the blood, spontaneous return of the blood in less than 3 seconds. But in children, we take it on sternum. Okay. Then there is no pallor clubbing. So for pallor, usually in adults we check for like lower palpebral conjunctiva, but in children we check for it in palms, soles, and tongue. Okay, if it could be some degree of pallor is there or not. Here it is not there, and there is a bilateral pedal edema is present. Now this bilateral edema, this one single finding is actually pointing me towards directly to a case of SAM, that is severe acute malnutrition is there. For SAM, there are three criteria, that is weight for age less than minus 3 standard deviation, mid upper arm circumference less than 11.5 centimeter, and bilateral pedal edema. And all these criteria are OR. So if any one of them is being fulfilled, we categorize it as a severe acute malnutrition. So here it is severe acute malnutrition. So now we know a respiratory illness with SAM. Then head to toe examination, utmost important, and we need to start from the head in sequence. So head, they are sparse, lusterless. So this lusterless is pointing me towards some micronutrient deficiency like zinc deficiency, and it can be this zinc deficiency can also be seen in cases of ectodermatitis enteropathica. Okay. Then anterior fontanelle, it is closed. Normally the anterior fontanelle closes by 18 to 24 months, and posterior fontanelle closes at birth, but in 3% of cases it is open. And for this anterior fontanelle, you need to take measurements. It is a rhomboid shaped anterior fontanelle, and for measuring it, you measure it diagonally. So you take from this point like this. Okay. And then you have to specify what are the measurements. Usually it is 2.5 into 2.5 centimeter. Okay, so then you have to check that this anterior fontanelle is sunken or bulging. If it is sunken, it is seen in cases of dehydration. So as of now, we haven't find any sign of dehydration in the child. It is bulging. It could be pulsatile and bulging in cases if the child is crying, or in cases of raised ICT, it could be just bulging. Then parietal bossing. So there is a frontal bossing and there is a parietal bossing in children. So this parietal bossing can be seen in rickets, or I say vitamin D deficiency can be seen parietal bossing. So there is a micronutrient deficiency also in the child. The eyes, you don't have to just say it is normal. You need to specify that yes, I have seen that it is not sunken, to rule out any dehydration in the child. Cirrhosis without spots for vitamin A deficiencies, KF ring for Wilson's. Another disease is if I have found the hair to be kinky hair, or that is in Menke disease. Kinky Menke disease is there, and that is also associated with ceruloplasmin, that is a copper transporter. Okay. The nose, what in nose you need to check that no deviation and no LR nasal flaring. So these are the LRs of the nose. So when there is a redness or there is a flaring of these LR, when they are flaring up or there is a redness in these LR, we say the child is going under respiratory distress. So it is a danger sign. So I'm trying to rule out is there any respiratory distress in the child or not. Then mouth and the oral cavity, no chillosis. Okay, no vitamin deficiencies are there. Dental formula, I have to specify the tongue is moist. So there is no dehydration. The cheeks, they are hypopigmented spots, which is pointing towards vitamin D deficiency. In knuckle hyperpigmentation, though it is not here, but knuckle hyperpigmentation points towards vitamin B12 deficiency. Koilunaica points towards iron deficiency, leukonaica calcium deficiency. So there is vitamin D and calcium deficiencies present in this child. Wrist widening is also seen in cases of vitamin D, or I say it is seen in cases of rickets. So there is this wrist, when you just do like this, there is a prominency of this wrist. Widening can be seen in the radial wrist. The skin pinch test is normal, that is it resolves spontaneously. So when you pinch the skin of the child, if it goes back spontaneously, that is in less than 2 seconds, it is spontaneous. But if it is delayed, like it is taking more than that, 2 to 10 seconds, then you say that it is slow and very slow. It resolves spontaneously when there is no dehydration. It takes time, slow in some dehydration and very slow in cases of severe dehydration. There is a flaky pinned dermatitis pavement like appearance. This is seen in cases of kwashiorkor, which is protein energy malnutrition. So now I know this SAM is due to this protein energy malnutrition. What kind of SAM? It is kwashiorkor. If I see a baggy pant appearance, if there is this baggy pant appearance, it is seen in cases of marasmus and due to subcutaneous fat loss. So I see baggy pant appearance. Okay. So then chest, there is erect rosary is present and Harrison sulcus. So these are findings, and the bowing of legs, they all are pointing me towards rickets. So this is basically the rachitic rosary. If I see that, you see this, the prominency, This is the rachitic rosary, and the sulcus, when I talk about this indentation, is basically the Harrison sulcus. So these are the findings for rickets. For bowing of legs, this is bowing of leg, which I also say as genu varum. This is knock knee, which I say as genu valgum, and this is windshield deformity. This windshield deformity and all these genu varum, genu valgum, the three of them are seen in cases of rickets. You can find all these three findings, any of the three findings can be found in rickets. Then moving on to anthropometry. So you cannot choose to miss upon the anthropometry. This is the most important. General physical examination, much more important than your systemic as well as your anthropometry. So for every child, you need to consider the weight as well as the height. Even if the child is like 16 or 17 years old, you still have to calculate the weight and the height, and then you have to plot it and calculate the BMI. Okay. So if the neonate is being provided to you less than 28 days, you use Fenton's chart. If less than 5 year age group is being provided to you, you use WHO growth chart, and if it is 5 to 18 years, then you use IAP growth charts, Indian Academy of Pediatrics. So you calculate the weight, and not only you have to calculate, you have to interpret as well. So you plot the weight for age on the WHO growth chart, and here we have plotted the weight for age. So it is 12 kg and it is lying below less than 3 standard deviation, or okay. So it is lying in a less than 3 standard deviation. It is, and the interpretation would be the child is wasting. Anything lying between +2 to -2 standard deviation would be considered to be normal by definition. So the height, normally what happens at birth, the height of the child is 50 centimeter, and at 4 year of age, the height usually doubles. Okay, so while we plotted the height for age, it is lying between -2 to 0, that is normal. Head circumference and all these findings of this head circumference, chest circumference, and mid upper arm circumference are taken till 5 year of age. Okay, so head circumference is usually greater than chest circumference at birth, but it is, the difference is not more than 4 centimeter. And the head circumference becomes equal to chest circumference by 6 to 9 months. So it becomes equal. Then mid upper arm circumference. So the mid upper arm circumference, if it is less than 12.5, considered to be a malnutrition, then it could be a moderate or a severe. And if it is less than 11.5, it is a severe acute malnutrition. So we have interpreted it to be a case of severe acute malnutrition. Now, how do we just calculate the mid upper arm circumference? Just have an idea in mind that we ask the child to mid flex his hand. Okay, we ask the child to mid flex his hand, and while the hand is mixed flexed, we point from the acromion process till the olecranon process. Okay, so till the acromion to olecranon, we measure it. Okay, with the help of the inch tape only, and when we measure it, we mark. Okay, while the hand is mid flex, so we mark the midpoint, and while taking the measurement, while we are measuring it, we will make the hand straight. We make the hand straight, and then we measure it, and we measure it by crossing over. So if there is this hand, we just mark it and we make it crossover. So by crossing over it, we measure the mid upper arm circumference to avoid any kind of errors if there are any. Then it has been plotted, the height has been plotted on WHO growth chart as well as the head circumference. For less than 2 years, we take the length, and for more than, we take height by stadiometer and length by the infantometer. Then systemic examination, let's just quickly brush it. Per abdomen, it is normal. What is important that you check for any hepato or splenomegaly, it is palpable, and on percussion, you need to calculate the liver span. So here, according to this age, it is 4 to 5. It is normal, the liver span. For hepatomegaly, while you are palpating it, so sometimes the liver can be palpated, and it is below the 2 centimeter below the costal margin. But then you need to check for the percussion to calculate the liver span, if it is actually enlarged or not. Okay, so then you have to differentiate. Then auscultations, bowel sounds are increased due to diarrhea. On respiration, this has been seen even on physical examination. There is a dull note and there is a reduced breath sounds. So for breath sounds, the breath sound you need to check that the chest is moving symmetrically. You normally make the patient lie supine and put paper. So if it is raising equally, then the chest we say it is bilaterally symmetrical, moving well with a respect. And on the breath sounds, you normally put the hand on the shoulders, and if they're rising equally, then it is normal on both the sides. And other the way is from the scapula, from behind the back, you put it in the interscapular region, and while the thumbs are moving. So by these methods, you can check for the breath sounds if they're reduced on one side or not. And we have found that it has been reduced. The vocal phragmitis has been reduced, which we check by placing the hand in the intercostal spaces on both the regions of inframammary interscapular, and auscultations by using the stethoscope. We make the patient count or make him say things, and now we can compare that is it been reduced or not. We have fine crepes heard at left infrascapular area. So this fine crepes or crackle is now making me clear that there could be a pneumonia. So a pneumonia is present in the left lung, lower lung. So yes, we have a case of lower respiratory tract infection, and most commonly the left lower lung is involved. CVS here it is normal. For CNS, you don't start with orientation, but you can make sure that the child is conscious. You can check some attentions or the memory of the child. For cranial nerves, you need to check for any strong smell for cranial nerve 1, for pupillary reflexes for 2, ocular movements for 3, 4, and 6, for any angle of deviation or the loss of wrinkles on the forehead for 7, vestibular components by 8, and gag reflex by 9, swelling disfigurement by 10, and spinal muscles, the trapezius muscles movement, it can be checked by 11, and hypoglossal, the tongue movements can be checked by 12. They are intact. The neck stiffness is present, which is presenting with the neutral rigidity. So what is this? While we make the patient supine and we tend to flex the head, so if we find some resistance, then we say the neck stiffness is there. Or while sitting, we can check by flexion of the head or the sideways movement of the head. If there is some resistance or there is stiffness, we say neck stiffness is present. Other signs are Brudzinski and Kernig signs. For Brudzinski, we make the patient lie in a supine posture and we flex the head, and out of pain there would be the flexion of the joint. So this would be a Brudzinski sign. And for Kernig's, while the legs are being flexed, we try to extend the knee. So usually what happens, this is the knee, and when we extend the knee out of pain, the head would be flexed. This would be Kernig signs. So these are both the signs pointing towards meningitis. Here they are negative, but still, it is difficult to perform in a child, but it is doable. Still, if they are negative, we cannot rule out meningitis out here because there is a neck stiffness is present. Okay, so we would be performing CSF examination, but we need to check if the ICT is raised, we cannot do a lumbar puncture. So then for motor examinations, we don't check much of the sensory examination in the children because it is difficult to elicit, but we can check for the motor. And here the power is 5 by 5, tone is normal. The tone could be increased in cases of cerebral palsy. There would be a high resistance and there would be hypertonia. The limbs would be more stiff. As well, in cases of cerebral palsy in lower limb, we can see the scissoring gait. So when if you make the child a little stunned, they would you see that the legs cross. So there would be a scissoring gait in cases of cerebral palsy. Then we check for reflexes. So these motor and these reflexes are important in cases of CNS examination in a child. So for reflexes, it is +2, which is normal. If it is brisk or hyperreflexia, it would be a +3 and 4 grading, which are abnormal, which is seen in cases of cerebral palsy. Okay. What is important that we check for ankle reflex, knee jerk, biceps and triceps, and we need to remember the root values of it. So while we start from downwards, the ankle jerk, we just have to remember the countings 1, 2, 3, 4, 5, 6, 7, 8. So this ankle is 1 and 2, and we know the component would be involved would be S, sacral, S1 and S2. Then at a knee, joint, we would have number like 3 and 4, and the component would be lumbar, that is L3 and L4. Then moving on to biceps. So for biceps, it would be number 5 and 6, and obviously the cervical component would be involved. And for triceps, it would be 7 and 8. Again, the cervical component would be involved, C7, C8. By this, the root values can be remembered. Then we move on to the plantar response. So we don't say Babinsky sign negative or positive if we check for plantar response. We use the word plantar response. If it is withdrawal or extensor, or it is dorsiflexion, then yes, it is a Babinsky sign is positive only always. But the plantar response, this is what we check. So the plantar response, we make the sole of the child and we pass up a sharp uh, key or an object. So if there is normally what happens, the sole, if we pass it, it will flexed. Okay, there is flex. But in cases of cerebral palsy, it withdraws back. So if it withdraws back, then we say Babinski sign is positive. Okay, so it is seen in cases of cerebral palsy. This is Babinski sign. Okay, and the plantar response here, it is negative. The plantar response is positive, which is Babinski sign. There are 5 components of Babinski sign which you need to know. That yes, there is abduction of toe, there is abduction and fanning of toe, there is abduction, there is fanning of big toe, then there is flexion at knee joint, there is contraction of tendo-Achilles muscle, as well as there is contraction of tensor fascial artery in our leg. Okay, so these are the 5 components of Babinski sign, which is asked and you need to know. Then summarizing it, the history has been summarized. Talking about the relevant examination, we know there is bilateral pitting edema, the weight is less than, so it is pointing towards severe acute malnutrition. There is reduced vocal fermenters. There are crepes, which is hurt, which is pointing towards pneumonia. There is neutral rigidity, which is pointing towards meningitis. Okay. So what, as far as now, what I have understood is that there is some lower respiratory tract infection in a child, which has disseminated to result in a meningitis. Okay. And I understand there is already a lot of risk factors for all this occurrence because it's a case of SAM and it has a rickets also. Micronutrient deficiency is also there. It's a case of SAM as well as rickets, and there is an lower respiratory tract infection which has caused me meningitis, and this it is leading to a seizure, which is GTCS, seizure one episode which the child has experienced. Now let's just talk about some differentials which we can keep in mind. So my first differential remains pneumonia. It could be a lobar or bronchopneumonic patchy consolidations. We can confirm it on investigations. Tuberculosis is so endemic to India that we just don't rule out on histories. We do go for an investigations. Lung abscess could be there. Then for a CNS examination, it could be a seizure. Now this seizure could be of any infectious etiology like meningitis, tuberculosis, or some electrolyte imbalances like hypocalcemia also, as the child is presenting with hypocalcemia, vitamin D deficient, rickets is there. Then some encephalopathies could be there. One thing which I talked about, some behavioral disorders in the children like breath holding span. So if the demands are not fulfilled of a child, the child usually tends to hold his breath and become cyanotic, become bluish. So this is the tantrum which the child does, and there is a psychogenic seizure which I talked about, commonly seen in teenage groups. Kawasaki disease was there in COVID-19 duration. It normally affects less than 5 years of age. Can recommend. Okay, so I just diagnosed my case that a 4-year boy, probably a case of acute respiratory illness. That is, I know lower respiratory tract illness, LRTI is there, which is now I know CREPs are there. So the left lower lung is involved. That is, left lower lung pneumonia is there, and with the complications. Now it has been complicated due to a bacterial meningitis and with rickets and complicated SAM. Okay, so the lungs would be affected, and the diarrhea could be an associated symptom over here. Okay, So as I talked about, this could be an associated symptoms to respiratory illness as well as meningitis. And there would be some organism which has migrated from the lungs, disseminated to the meninges, which has resulted in meningitis. And this meningitis is actually causing me the seizure. This much as I can know, I can make. So, and the risk factors which I understand, it is a case of SAM and rickets and nutrient deficiency. So whenever a case of SAM, it could be a complicated or uncomplicated. When the infectious etiology or a systemic illness has been reported, like in this case, there is a respiratory illness, we termed it as a complicated SAM. Okay, and hence our management would change to 10-step investigations. Okay, so now I understand most probably a bacterial pneumonia which has disseminated to meninges resulting in bacterial meningitis and which is now causing me the seizure and diarrhea as an associated symptom towards it. Then on investigations, the leukocytosis is there. We perform Montux and sputum. If the child is not able to produce sputum, we do gastric aspirate with nasogastric tube. We aspirated chest X-ray. So here we see the chest X-ray, and we see on the right side this is the costochondral junction, which is quite marked. But on the left side we see there are some consolidations. Okay, so there is some patchy consolidations. So these are basically pneumonia. So the left lower lobe is involved, which now I know it has been confirmed on investigations also that yes, the child is having pneumonia. Normally the X-rays are taken in a supine view in cases of children. Here, while performing the calcium, so calcium is normally 9 to 11, but here it is reduced. In cases of preterm, it is less than 7. We consider it to be hypocalcemia. For vitamin D, the usual value is 10 to 20. That is insufficient value. If it is less than 10, then it is deranged. So the vitamin D has to be at least more than 20. Okay. Then blood culture, when the blood culture were given, it came out to be a streptococcus pneumoniae. So now I know the bacteria is streptococcus pneumoniae. The two bacteria commonly which could be associated, one is streptococcus and one is haemophilus influenza. And both of them, they can result in pneumonia and then disseminated to form me a bacterial meningitis. As well as the antibiotic sensitivity is being performed, so it is sensitive to all the available antibiotics. Okay, so I know I can start up my empirical regime of ampicillin and gentamicin. The CSF examination reveals to be a bacterial meningitis with glucose reduced. It is turbid, whereas in cases of viral, it is clear, and in cases of TB, we see a cobweb formation. Okay, so this is a picture of a bacterial meningitis. Then managing up the case, as I talked about, it has to be managed with a 10-step complicated SAM management. But the general management just have a view that yes, IV fluids, the empirical of if any infection is being given to you, so what antibiotic should actually come into mind? You say that yes, we start with empirical treatment of AMPA and Genta. You can just simply say it. Okay, that is ampicillin and gentamicin, which covers quite a range of organisms. This empirical formula can be started, and later on we can change according to the blood culture because the usual report takes around 7 days to come. Then there are cephalosporins which can be started, and vancomycin if there is a staph infection not resolved. Dexa cover can be given, and for vitamin deficiencies we know the vitamin D as well as calcium doses which are given in the child. So let's talk about the 10-step complicated SAM management. It covers everything, whatever there is in our child. So there's an initial treatment, stabilization phase, and then rehabilitation follow-up. So the 10-step mnemonic is HH die with E coming first, mix. MICS. Okay, so this H is hypoglycemia. You treat hypoglycemia with dextrose solution. Hypothermia for warmer is given. For dehydration. For dehydration, if you are correcting it, one thing we should know that in dehydration there could be no dehydration, some dehydration, and severe dehydration. There is no mild, moderate, and severe. There is no some and severe. If the child is comfortable uh, giving water, it's adequate, then it is no dehydration. Skin pinch test, skin tour test, it is normal. It is no dehydration. If the child is irritable and the child is thirsty, and whenever the water is given, the child drinks it quickly, the skin pinch is slow, and there is some kind of irritability to the child, we consider it to be a some dehydration, and sunken eyes are there. Okay, but in severe, the skin pinch would be very slow. The child would be in a comatose or a unresponsive state. So even if the water is being provided, the child would not be drinking it because the child is in a unresponsive state. So accordingly, our management would be, for no, it would be a plan A, plan B, plan C. Okay. Plan A could be home-based management. ORS is provided. In B, we need ORS. It is a hospital-based and IV fluids. And C, it is IV fluids in ORS. And this IV fluids in ICU setup or in hospital setup has to be provided. So we talked about some ORS, which we need to know. The oral dehydration solution. We usually mix the sachet in 1 liter of water. We boil it and cool down. For Rismols, we use it 2 liter of water. The lowest molarity ORS, we use 2 liter of water. For ORS, we need to know the components. It is sodium chloride, potassium chloride, it is sodium citrate, and glucose. Okay, so the values, it is quite easy to remember: 2.6, 1.5, 2.9, and 13.5. Total count to be 20.5 grams. Whereas in cases of millimoles, when I talk about, so it is sodium, potassium chloride, citrate, and glucose. Okay, and all this is 245 millimole. The glucose being the 75, and I know there is a sodium glucose symporter, so the sodium is also 75. Both of them are transported simultaneously. And a little below that would be a chloride, because this chloride has sodium chloride also, potassium chloride also. So this is 65. For potassium, it is 20, and half of it is 10, that is citrate. Okay, this is our ORS constituents which we need to remember. Additionally to it, we provide zinc to the child, and this zinc, if the child is less than 6 months, we give it as 10 milligrams. If it is more than 6 months, we give it 20 milligrams, and this is given for 14 days. And this zinc reduces the severity of diarrhea as well as duration of diarrhea. These are the two important points for zinc. Okay, and for this we have another like a small oral rehydration solutions for malnourished kids also. This much we have to remember. Then moving from dehydration, then we have the IV fluids regime also. So the IV fluids are given in two parts. One is 30 ml per kg and one is 70 ml per kg. Okay, and for this we have the child less than 1 year of age, more than 1 year of age. So for less than 1 year of age, we go slowly, so we cover around 6 hours, and for more than 1 year, we go for 3 hours. So the in the first hour, the 30 ml per kg is given, and for 70 ml per kg, we give 5 hours. Then in case of more than 1 year, it is around half an hour, that is 30 minutes, and then 2.5 hours, the later part. Okay, this is for the IV fluids. Then the dehydration being covered, then we collect for any electrolyte imbalance, like here if there is sodium, potassium, any electrolyte imbalances there. For calcium, gluconate would be provided, calcium gluconate would be provided. Any infection, we would be treating for 7 days with antibiotics. Ampagenta could be given, or the relevant antibiotic can be given like penicillins. Then we treat the infection, and after treating the infection, we correct for any micronutrient deficiencies with iron and without iron. Firstly without iron, and then we will add the iron later on after 7 days. Vitamin D can be corrected. Then we will start the feeding. So we start the feeding with F20, F75 and F100 diet. And while we are discharging, we also start with ready to use therapeutic feeds. Okay, so these are the feeding guidelines. Ready to use therapeutic feed, and this ready to use therapeutic feed can be given in uncomplicated SAMs at home based management also. And at that there at home based management, we make sure the ASHA workers also to visit the home facility. Then we go for the catch up growth and emotional development, and then we prepare for discharge. So for discharge, we will explain all the danger signs and when to return to the hospital if there is any kind of danger sign visible in the children. So this was the management of a complicated SAM with the respiratory illness ongoing and the meningitis. So what's important in a pediatric age group? You need to remember that the first important thing is your immunization history, the NIS schedule you need to have on tips, the developmental history which is of important, the milestones have to be on tips, the dietary history has to be important. You have to mention the dietary history in every case. On examination, the general physical examination is of utmost importance from head to toe, and the anthropometry. So in every child, you have to take the anthropometry. These are the things which you cannot choose to flunt must know areas in a pediatric case. What are the other pediatric case which you can be allotted? So one, as I talk about a respi case, most commonly it would be a pneumonia. uh, Other than that, some GIT cases like a child with loose motion, so diarrhea or a dysentery could be there, and enteric fever could be there. Other than that, if there is a hepatitis, jaundice, then you can think of viral or amoebic hepatitis, and liver abscess case can be provided to you. In CNS, there would be a case of seizure, epilepsy, cerebral palsy, global developmental delay would be there if there is any. And then CVS cases are not much provided, like PDA or a VST can be given, but not much. In a hemat, the cases could be of anemia, and then this anemia you need to check if there is any lymphadenopathies, palpitations, splenomegaly or not there. And then if these findings are there and there is a chief complaints of fatigue, easy fatigability, you know that you can think of ALL, acute lymphoblastic leukemias. So these cases can be presented. Other than that, could be a nephrotic syndrome, which we discussed in a short detail. The patient having generalized swelling and asarca, and any of these cases can be combined with SAM. So always you have to check, as well as the Rickets, any vitamin or micronutrient deficiencies is there or not. The four important things have to be covered: immunization, developmental, dietary, and general physical examination. And with